This is about safe inter-hospital transfers, and we look at a case study and then we use the inter-hospital referral and transfer guidance and the STOPP tool to assess the child ready for their transfer. So these are the aims of our session. So looking at preparing the patient for a safe transfer, utilising the STOPP tool and the inter-hospital transfer guidance. That's an STPN guidance that you can find on our website, which we'll show you later. Sarah. Right, so we're going to look at this case study. So you take a history, and this is a 6-week-old baby boy called George, and he's referred to the paediatric assessment that you're working on by his GP. He's the mum's first baby, and he's term baby, and he's breastfed, but there's been a history of being referred to the health visitor. The health visitor having concerns over the baby's weight and a pattern of not gaining weight, so failure to thrive. He vomits after feeds, but mum says that babies vomit after feeds, don't they? So she's not overly concerned over that, although it's been a difficult time, and he's often hungry and he's very unsettled often. But today he was more lethargic and she was worried, so she brought him to the GP, and now he's come to you. So there's a bit of interaction here, which will make it a bit more exciting, I hope. So based on this information, what are your main concerns? Lethargy, yeah, that would stand out to me as a paediatric nurse as well. Worried about dehydration. Yeah, if they've not been taking milk, and then more vomiting milk. So yeah, lethargy is definitely coming out as a strong point there. But yeah, his background and it being an ongoing issue. Somebody else is worried about sepsis, I guess linked with the lethargy, and the fact that it's worsening. But yeah, the suddenness of the decline today. So you go on to examine the baby. He's sucking on his dummy vigorously, although quite sleepy. His respiratory rate's 45 breaths per minute, but there's no respiratory distress, and his chest sounds clear when you auscultate. His heart rate's 180 beats per minute. His blood pressure is 80/35. He's quite mottled and pale, and he has cool extremities. His capillary refill time is 3 seconds. And you noticed he's got reduced skin turgor, and his mucous membranes are quite dry. He is a little bit lethargic, and he has a mildly sunken fontanelle. His blood sugar is 3.8 millimoles per litre. And you do an abdominal palpation, but you don't find anything specific that you're worried about. So with that information and your earlier concerns, what initial investigations do you want for this baby? Great. So you want to see a blood glucose, and you want a blood gas. You want to see the lactate, the CLP, culture, bloods generally, and an abdominal scan, a full blood count. Great. So what would your immediate management be for this baby without any of those results back yet? What would you want to do for your baby? Okay, so everyone wants to give fluids. I think that's a good idea. An A to E assessment, yeah, and approach to interventions, antibiotics, and keep the baby nil by mouth. Lovely. So you cannulate the baby. The cannula doesn't go in easily, but you do manage to get a vein. You take some bloods, a full blood count, urea and electrolytes, the CLP, and a blood gas. And you give some fluid resuscitation. So you give 10 mils per kilo of sodium chloride because of the signs of dehydration, the tachycardia. And then you may need to repeat that, and you reassess following that fluid. And then you also set up some maintenance, and 0.9 and 5, adding potassium once you know what the blood gas result is for the potassium at a higher rate than normal at 150 mils per kilo per day. And then your blood gas is back pretty quickly. And this is what's on your gas. So you've got a pH 7.5. I'll just let you read through that. Lovely. So what do you make of the blood gas result? What stands out as abnormal? You can list all your concerns. So somebody's calling this a metabolic alkalosis. Thank you. Okay, so yes, we've got a metabolic alkalosis. You're right, and we've got some hyponatremia. Yeah, a couple of you have said that with different spellings. Yeah, I don't blame you. That's a spell check. It's the nasty word. And hypochloremia. Do you want to go on to the next slide, Sarah, please? So yeah, there's also hypokalemia. The potassium was borderline hypokalemic, wasn't it? 3.5 or 3.6. Hypochloremic, and it's definitely a metabolic alkalosis. The hypokalemia because the potassium's low, hypochloremia because the chloride is low, and the metabolic alkalosis is, we know, is there because of the high pH, and it's caused by the high bicarbonate and the low CO, and normal CO2 on that gas. So the prolonged vomiting has caused the progressive loss of hydrogens and chloride and potassium, which is producing the metabolic alkalosis. And there's less bicarbonate secreted there's decreased secretion of pancreatic bicarbonate as well, and there's a loss of potassium in the kidney. So based on that, what is your principal diagnosis? You may still not have an idea, and that's absolutely fine. But if you're thinking about something, what would it be? Yeah, so there's some agreement that pyloric stenosis could be the diagnosis, but there could be another condition causing the vomiting. Absolutely. So what else would you want to know to be able to confirm whether it's pyloric stenosis or not? What other things would help you make your decisions? Yeah, so an ultrasound and test feed would sound like good ideas. So yeah, you decide that George might well have pyloric stenosis. In the absence of the metabolic alkalosis, that'd be much less likely. There'd be a much wider range of possible diagnoses. But yeah, you think you're dealing with pyloric stenosis. But what are the differentials if you've got a baby that's presenting with pyloric stenosis? What else could it be? So we've got a dehydrated baby. We've got electrolyte abnormalities. We've got vomiting. Yeah, gastroenteritis. Could be sepsis. So you decide that the other possible causes of George's presentation could be gastroesophageal reflux. So particularly with the weight loss and the alkalosis, it could be gastroenteritis. Potentially overfeeding is something to think about. If careful feeding history has been taken in the absence of weight loss, it could be overfeeding with persistent vomiting. Bartter syndrome, it's a rare renal cause of hyperkalemic alkalosis in babies, but it's important to consider, especially with vomiting as a dominant feature. A cow's milk protein allergy, or it could be infection or sepsis. Thank you, Sarah. So you refer to the surgeons in your hospital and they agree with your concerns. So they'd like to try a test feed like you suggested. And following their examination, they show you a classic presentation of pyloric stenosis and teach you to see the peristaltic waves from the left upper quadrant of the abdomen to the right iliac fossa and palpation of an olive mass. So the surgical team support your decision to refer to a specialist paediatric surgical centre. But to confirm your suspicions, you order an ultrasound, again, like you suggested, looking for evidence of a pyloric mass and passage of fluid through the pylorus. And the findings of a single wall thickness of greater than 4 millimeters and a channel length of greater than 14 millimeters is considered significant. And a mass is seen on George's ultrasound with increased wall thickness at the pylorus. But it's really important that the sonographer is experienced in infant scanning. because otherwise, if everything else fits together but the ultrasound scan doesn't fit the picture, it's something to question. Sarah. So you've got this surgical baby to refer now. So it's a good time for us to show you the inter-hospital referral and transfer principle guidance that the STPN set out. It's a really useful guide for junior doctors that are learning the process of referring patients to other hospitals, and it's useful for the nursing teams that are organising the transfers. They just outline the basic principles of and there are appendices of which hospitals transfer to which tertiary centres, and this appendix at the end here is really useful for highlighting the time frames for which different surgical transfers need to happen within what time frame. So you can see pyloric stenosis is there at the bottom of the amber pathway, so it's a non-emergency transfer, and it gives some time frames, but I'll cover that in the next slide. And then things like bilious vomiting are on the red pathway, and let's see, a hydrocele is on the green pathway. So it just gives you some idea around time frames and guides that decision making. So you contact the paediatric surgical registrar on call between 7 AM and 10 PM at the designated primary tertiary centre, and that time frame is set out in the pyloric stenosis guidance, which I'll show you later. But the level of care that's been highlighted, like I said, is amber. So it's a non-emergency transfer, hence the during hours referral. The referral should be accepted within 30 minutes. A bed may well take longer, but that is what the guidance asks for, is a referral acceptance within 30 minutes. But then the surgical input can be as long as 24 to 48 hours away. So in your hospital, you can keep that baby and keep working on stabilising them before they get moved. There's no urgent rush to get them out. And the grid at the bottom just shows you the tertiary centres and the pathways that for most general surgical issues, they go to those tertiary centres. So while you wait, you explain to George's family that he needs surgery, but it's not urgent, and he needs the salts and acids in his blood to return to normal first. Explain why George is being transferred and give a realistic idea of the time frame, i.e. that it's going to be 24 to 48 hours before he gets moved and has his surgery. But you start preparations early to transfer George, because when a bed's available, you want to be ready to take it. You hear that George has been accepted by the surgical team at St George's Hospital, and they will call you back when there's a bed available. So what tool is available to you to be able to support a safe transfer of George to St George's when the time is ready? So the STOPP tool, so the safe transfer of paediatric patients tool that's endorsed by STRS, by STPN, and also was actually created by the Thames Valley and Wessex paediatric network. So this is what the STOPP tool looks like. So you start a STOPP tool form for George. Could you go online and bring up a STOPP tool for us, Sarah, so we can assess George ready for his transfer? Okay, so there's a long page at the front with all the details, but let's go straight to the patient risk assessment, because that's what really matters. So we'll do an ABCDE assessment of him, and then there's some further questions at the bottom, and we'll see if he triggers any of these assessments. So is there a risk of airway compromise? No, I don't think so. Is the respiratory rate outside the normal age adjusted range? No, not really. Any evidence of respiratory distress or increased work of breathing? No. No need for oxygen? No. Definitely not intubated and ventilated. The blood pressure or heart rate outside normal age is, yeah, he's significantly tachycardic. He's up in the 180s. Signs of poor peripheral perfusion. Yes, his capillary refill time was 3 seconds and he was pale and mottled. His lactate, I can't remember what his lactate was. Was it elevated? We'll say no. I think it was borderline. Fluid bolus greater than 40 mils per kilo. No, he's had 10 mils per kilo, and we were going to go back and reassess. His GCS low, no, he's not fully as vigorous as he should be, but his GCSE isn't altered. No signs of raised intracranial pressure. No new diagnosis of erroneous metabolism. He's not pyrexial. Temperature's fine. Is the patient shocked? You could argue he's shocked. Is he adequately resuscitated? Well, not yet. We need to go back and look. Does pain control become an issue? No, he's not happy, but it's not pain. Does the child have communication difficulties? No. Time critical? No. Risk of progressive intracranial event? No. You can tick no for all the rest of those. Thank you, Sarah. Thank you. So yeah, I think we need to go back and reassess George, please, Sarah. Go back to the slides. Lovely. And a team approach is best with the STOPP tool. You know, nurses should and could instigate it, and you know, when you get your findings, it should be discussed as a team as to what the best solutions are. So George triggers the STOPP assessment for the tachycardia and prolonged capillary refill. And I felt like we could justify marking the shock criteria too. But we've got time on our side in terms of getting him ready for the transfer, but those triggers certainly need addressing now. So you decide that George needs further resuscitation based on the reassessment following the fluid, and he's still in signs of shock. Is there any other management that George might benefit from while he waits for his transfer? So in addition to additional fluid, what else might you do for a baby with pyloric stenosis? Well, you wait nasogastric tube, lovely. Yeah, keep him nil by mouth. Yeah, and keep his tube on free drainage as well. Yeah, the replacement fluids, and keeping really close eye on that potassium. If it's low and they're passing urine, it's really important to be replacing the potassium. Keep monitoring the gas, and the urea and electrolytes. So and a second IV access. That sounds like a very good idea. So you can keep up with the fluids and you've got a backup. And monitoring the gas should be 12-hourly unless you're needing to monitor the potassium and sugar more regularly than that. Although once you're on the right fluids, that shouldn't be such an issue. Further management, you can utilize the pyloric stenosis guidance. So that's also on the SDPN website. It runs the guidance for lots of different general surgical issues that need transferring are all along the top of the inter-hospital transfer guide as well. So if you look up the inter-hospital transfer guide, pyloric stenosis along the top, and so is interception and bilious vomiting, things like that. But yeah, the guideline says to keep nil by mouth, to insert a nasogastric tube, put it on free drainage, and then continue fluid resuscitation. And you can replace the NG losses mil for mil as well, but in discussion with the surgeons, but looking after him too. And again, keep replacing the potassium as long as he's not in like a pre-renal failure, and holding on to his potassium because he's not weaning. So yeah, you repeat a gas every 12 hours until the alkalosis is normalized. And George required, this was the slide I was after, I needed a bit earlier, didn't I? We've been very slow to give this second fluid bolus. So George required a second and third 10 ml per kilo fluid bolus before his tachycardia really settled, as well as giving the increased fluid IV maintenance alongside. And then once his basic CES was back down to within normal range and the chloride was above 100, you can reduce the fluid rate back down to the normal 120 mils per kilo per day. So last, you get a bed confirmed at a designated primary tertiary centre. So you want to reassess using the STOPP tool again and prepare for the transfer. So you use the STOPP tool going back through all that checklist for your second reassessment, and nothing triggers this time. The heart rate is nicely down. His assessment is much better. He's no longer pale. He's got nice warm peripheries, and capillary refill time is nice and brisk. So you document that, and you put the STOPP tool with your own observation chart and organise transfer. And the STOPP tool will will guide you on who to send with George, because he's not triggering anything. It's and he's just on IV fluids. The STOPP tool points towards him going with a paramedic or a nurse. So you've organised your transfer, and George is safely transferred with his cannula, IV fluids and his nasogastric tube, or free drainage, and copies of his documentation to St George's Hospital.